This is breaking news from News 8.
Well, we have a lot of updates for you regarding coronavirus this afternoon. Governor Cuomo is speaking right now. That's streaming on our website, rochesterfirst.com. President Trump, members of the coronavirus task force, are expected to speak soon. But first, medical experts at UR Medicine are discussing how the local testing process works, and we're going to take you there first live.
Right is Dr. Paul Grayman, hospital epidemiologist for UR Medical Center. To my left is Dr. Dwight Hardy, Director of Clinical Microbiology. To Dr. Grayman's right is Melissa Allen, Director of Operations for UR Medicine Labs. And to Dr. Hardy's left is Dr. Nicole Pecora, Associate Director of Clinical Microbiology at UR Medical Center. Since the outbreak of COVID-19 overseas, our clinical staff in Central Lab have been working with the state and local governments and obtaining equipment and supplies to provide COVID-19 testing. We appreciate the support that we have received from the Governor's Office, Clinical Laboratory Evaluation Program, and Wadsworth Laboratory. Thanks to the collaborative work, we began processing COVID-19 tests on Monday. Dr. Hardy, Dr. Pecora, and Melissa will explain more about that in a few minutes. I understand our communications team has provided some video of the test process for you. Given the growing number of cases nationally, all of us are worried about COVID-19. We want to protect ourselves and our loved ones. And if there's any possibility of being infected with COVID-19, we want to know right away whether we have it or not. It's completely natural for any patient who feels they have COVID-19 or that they may have come in contact with someone with COVID-19 to want a test. I wish I could tell you that our lab is able to process COVID tests for anyone who wants one. Unfortunately, that's not the case, not in our lab or in any lab in the country. However, our lab goes a long way to providing same-day tests for all the patients in the community who medically need one. Hospitalized patients, our first responders, and our medical staff and faculty who are working in the front lines and need to know whether they need to be taken out of work because of COVID-19. With that, I'd like to invite Dr. Mendoza to speak for a few minutes about the clinical guidelines for those who need to be tested.
Thank you, Dr. Apostolakis, and thank you all for being here today. This, as you all know and have been reporting on, this is a very dynamic situation, a lot of updates every day. I want to thank you all for your hard work here as the media. I know how hard you all have been working through this very challenging time and truly unprecedented circumstances. You know, and at no other time in my life have we seen this degree of a public level challenge where we all need to come together virtually, as it were, to tackle this collective challenge. Before I get into the issue of testing, I want to provide a short update on where we are as a county. Hopefully by now you've heard that we reported 8 new individuals with positive coronavirus testing, bringing the total to 30. Last night you also saw our alert about the individual who we learned about last night who came in on an inbound flight from JFK to Rochester on September 14th. The period of time that we're concerned about in the airport is in the 5 o'clock to 7 o'clock range, broadly speaking. We have the specific time there on our release. We have reached the individual. I personally conducted that contact tracing investigation myself, spoke to the individual, spoke to that person's family. To this point, we do not identify any other high-risk contacts from that individual. We are working with the State Department of Health to obtain the flight manifest from that inbound flight from JFK. But at this point, the guidance is that if you were on that flight, to follow your symptoms. And we can get into some of the details around that flight at a later time. So as to the question of testing, I absolutely appreciate the desire to want to test. if these were normal times, I think it would be a fair expectation to want to have that test done because it's completely understandable. And at the same time, these are not normal times. We have a public health challenge before us that we need to adapt to. We've got to find a way to adapt to these changing circumstances, and that does mean changing some of our expectations. And so part of my goal here today is to help guide the community around what are reasonable expectations to have around the issue of testing. So right now what we're dealing with is a shortage locally, regionally, nationally around some of the materials that are necessary to process these coronavirus tests. I believe that this is a temporary shortage. And at the same time, we know that every day brings a new challenge. And so it's likely that in a day or two or three, we'll have something different to say. But as of what we know right now, based on the available capacity right now, we need to keep working together to get ourselves through the challenges that face us every day. So as I see it, when we look at the notion of testing, it's not an issue of yes or no, but rather an issue of now versus later, versus perhaps not at all. But I really want to focus on now versus later because we need to prioritize those tests for whom the results will make a difference. And I said this yesterday at the WXXI studio. In medicine, we only do tests if it will change our management. And in this case, our management is social distancing. The management for this condition for the vast majority of people in this community who are not in the hospital is social distancing. And so I cannot emphasize enough the importance of that as our current treatment, if you will, for this public health crisis. So that means that whether you have a positive or negative test, the important guidance is that your treatment is social distancing. We want people to stay home because we know that that is the most effective way to contain the spread of this virus in our community. The next most important point I want to raise is that we would only really consider testing for people who are symptomatic. In general, only people who are symptomatic would even need a test. And along those lines, not all people who are symptomatic need the test right now. We know that 80% of individuals who contract this infection are very likely to have little to no symptoms. And so we have to ask in advance, will the discovery of a positive result change the guidance that we want people to stay at home? And my answer to that is no. We know that people who have a positive or negative test, who have very mild or no symptoms, can be very safely managed in their home. And given that the guidance now, compared to even a week ago, is very aggressive social distancing and remaining in our homes, given that we've seen the directives from the governor, from the federal government, around trying to contain ourselves in our homes, I think we need to put the guidance around testing in the proper context. Along those lines, if you are an individual who is contemplating testing, I would offer that you need to consider that you must isolate. So you are somebody who's symptomatic, so that is what would sort of open the door to you for being a candidate for testing, but we wouldn't want to consider testing if you are not prepared to isolate, because again, the reality is that if you have symptoms and you're a candidate for testing, if that test comes back positive, that would be a confirmed case, and we would want to do the appropriate contact tracing in the health department, but you need to be prepared to isolate, because that is, again, how you contain the spread of this virus. Now, there are details around other people who we might want to test, and that gets into really who are the high-risk individuals in our community. So again, people who are first responders, people who are in the healthcare field, individuals who are hospitalized are a priority, because the result of a test for an individual who is hospitalized will potentially greatly change our management in the hospital. So if, for example, somebody is critically ill in the hospital on broad-spectrum antibiotics, and there is a question as to whether they have a coronavirus test, if it comes back positive, the team taking care of that will be able to make the necessary modifications to take care of that individual safely. In that setting also, if that individual comes back with a negative test, then we might be able to say, well, we no longer need to undertake all of the PPE, respiratory precautions that are actually very resource and time intensive, because then we can focus on taking care of the issue that we know to be true if we find out, for example, that somebody does not have a coronavirus test. So there is a complicated way of thinking about this, and I want the public to come away with the message that if you have mild to no symptoms, you can stay at home very safely, isolate yourself, and then we can revisit this in a day or two. But right now, given the current status of supply, we want to be very mindful of how we prioritize our resources, because we have vulnerable individuals in our community right now that we need to take care of first and foremost. With that, I'm going to hand it back over to Dr. Apostolakis, and we'll take some questions at the end.
Thank you, Dr. Mendoza. I'd now like to ask Dr. Dwight Hardy, the Director of Clinical Microbiology, to make a brief statement.
Hi, good morning. So just as a brief introduction, I and Dr. Pecora are directors of microbiology here at U of R Central Labs. What does that mean? What it means is we perform the diagnostic microbiology testing for Strong Memorial, for Golisano Children's, for Highland Hospital, for F.F. Thompson in Canandaigua, for Jones Memorial in Wellsville, St. James in Hornell, Noyes in Dansville, as well as for hundreds of U of R providers in private practice. In addition, we perform services for other physician practices that are not part of the U of R system. The point being, we do our best to serve lots of patients, and the same applies to testing for COVID-19. We're doing our best to serve lots of patients, but we just at the present time don't have the capacity to do that, hence Dr. Apostolakis and Dr. Mendoza's statements about being judicious in who we test. A couple of things. One thing I'd like to mention, because there is, in my mind, lots of confusion in the community. Testing. Patients are being tested. Well, what does that mean? First step that's required is that a specimen must be collected. And that's what happens in the doctor's office at the urgent care. Okay? A specimen is collected with a swab that's inserted into the nasopharynx. This is specimen collection. It's not testing. Okay? That specimen then is placed into a transport vial. Okay? And this is what we in the laboratory then receive. So if there's virus on that swab and it's in this transport, this is where we begin testing. First step is to extract nucleic acid of the virus. Okay? And that's the first step. The second step, after we've extracted nucleic acid, then the next major step is nucleic acid amplification, okay? PCR, you've heard of, to detect the presence of the viral genome. And that's the actual testing that occurs in the laboratory, okay? So even these specimen collection kits are in short supply. So it even starts here in terms of being judicious in who we test. Even specimen collection kits are in short supply. Then once we get to the laboratory, and as I say, if I break it into two simple, oversimplified, first step is to extract. We now have platforms, instruments to do that, but reagents are in short supply. Second, we then do nucleic acid amplification. There, the issue is not so much, at least at the present time, shortage of reagents, but it's a highly complex, semi-automated procedure, which means there are lots of manual steps, and it's highly complex. Okay? So again, our throughput is limited by those issues that I've just tried to describe. So that all goes along with our hope is that the community tests only those who really need to be tested, because we are trying very hard to keep up with that and do our best to make a difference. And with that, I think.
Thank you, Dr. Hardy. I think with that, did you want to say something, Paul, or take questions? You good?
You know, I think it may be useful for the public to draw comparisons with the flu, something we're mostly familiar with. With the flu, when the flu season's really going on in full swing, we do test people for the flu. But one of the reasons we test them is that we have a medication to treat the flu. So it's important to know who has the flu. We can give them the proper medication. For COVID-19, at the moment, there are no treatments that are recognized at this point. There may be treatments in the future that we'll all, of course, embrace. But at the moment, if you have a positive test or a negative test, the treatment is pretty much the same. For most people who have this infection, more than 80% of them, it's going to be a cold, might be a bad cold, or it might be like the flu. You have to stay home, take liquids, maybe take Tylenol or other fever-reducing agents. The treatment is the same. So knowing a positive or a negative test is not going to make a difference in what your doctor is going to have you do. Staying home is number one, because that's how we prevent spread to other people. So the positive or negative test, for the vast majority of us who might have COVID-19 or not, the test is just not going to make a difference. And where the tests really do make a difference are for people who are sick enough to be in the hospital, where we need to know whether we have to isolate them or release them from isolation within our hospitals, because that has a huge impact on how we operate our hospitals, how many patients we can have, how many gloves and gowns and masks and so forth we use, which we're trying to preserve so that we have them when we really need them. So those are tests that really make a difference. Tests on healthcare workers who might be ill can also make a difference. If they don't have COVID-19, they can come back to work when their cold is better or their flu symptoms are better. If they have COVID-19, we're going to be a lot more careful, and they're going to be out for a longer time, and they're not going to be available to take care of all of us who might need to be in a hospital sometime. So the testing and using it judiciously, carefully, has a huge impact for all of us in preserving our healthcare system being able to work in the way we all want it to work. And for the vast majority of us who might have cold symptoms or flu symptoms from this, if we get it, the result of the test is not going to make much of a difference when it comes to staying home and away from other people and preventing transmission.
Thank you, Dr. Grayman. We'll now open it up for questions.
Dr. Mendoza, yesterday Erie County said they're completely out of the test kits. Are we close to that point? And is there no pipeline from the state or from the feds to get more?
Well, I'll defer the specific questions about capacity to my colleagues, but we do have avenues. We are testing. The U of R lab has ability to do tests for the people, again, who need it the most. Rochester Regional does have that capacity as well. Today, we're not going to be able to rely on Erie County labs like we did yesterday. And, you know, that is a changing situation. But we are working together so that if I identify somebody through contact tracing who needs to be tested, I know that I can call on my colleagues to say, can we fast track this one, because it has a public health importance. So again, I don't want the message to be that we don't have the capacity. We do have capacity, and we can run hundreds of tests a day. But we want to make sure that we're using that resource appropriately.
I'd like to ask Melissa Allen, Director of Operations for UR Medicine Labs, if she has any comments regarding this.
Sure. Thank you, and good morning. So we have been doing our best to prioritize all the sample collections that have come into our laboratory since we began testing, and prior to actually when we began testing. So far, we have received over 1,000 specimens within our laboratory that we have either triaged to process in-house in our own laboratory, or we have sent out to a reference laboratory or a public health laboratory to be reported. And so far, since we've sent out, we've received approximately 400 results back from a collection of all of those reporting sources, and we are doing our best to make sure that we can expedite those tests to a laboratory that can report them as quickly as possible for our outpatient setting.
Sorry, can you clarify? So 1,000 tests here. How many of those are you processing here versus sending out to other labs?
So we are a central laboratory, so what that means is that we receive a wide variety of specimens from all over our region that either get tested in-house here through any of our various laboratory sections, or we process those specimens, stabilize them, and refer them on to another large reference laboratory like ARUP, LabCorp, Quest Diagnostics, laboratory like that. And so we've received over 1,000. We've processed them. We've either sent them on to a large reference laboratory, a public health laboratory, or we've kept specimens in-house to test here.
If I could just, to follow to your question, in-house we've tested approximately 200.
Since Monday.
Yes. The balance that Melissa refers to were sent to either public health laboratory or commercial laboratory. One other thing I might say is, of the results that we have generated and the results that are starting to trickle in from commercial reference laboratory, at least 95% or greater are negative. 95% or more are negative for COVID-19, just to make that point.
And Dr. Mendoza, are all of the samples, are those 1,000 samples all Monroe County, or are you sending some to other facilities other than here that's sending them out?
So the labs that we receive here are coming from across the entire region, so including outside of Monroe County. The tests, the individuals that we're processing in the health department are all Monroe County residents that will either go to Erie County, Wadsworth, or in partnership with my colleagues, they may be processed through the mechanisms you heard about.
Are the ones that you're keeping and doing internally as opposed to shipping out the ones that are considered highest priority?
That's right.
And what's your turnaround time on those?
Less than 24 hours. It depends on, because it's a semi-automated process, each test run is several hours. So it sort of depends on when that specimen arrives and if it gets onto that run. So it's at least several hours, if not a full day.
Which underscores the importance of being judicious in how we order, because we don't want some healthcare provider's result to get put inadvertently into a pile that's going to go to a reference lab and take anywhere from 2 to 5 days.
That's right.
So we're going to want to prioritize that, and that's where collaboration across the community is so important. We want to identify collectively who those individuals are as a community, because at the end of the day, those are the results that we want to get first.
So the ones you send out, you're still sending those out because you could get the results quicker from the other labs.
Well, some of these were sent before Monday, and we've been waiting. So now we are prioritizing for the patients, for the first responders, for our frontline staff. We're doing those in-house, and then others we are still sending out. We're trying to be judicious where to send them to places that are able to do them in a more rapid fashion.
What are you getting into the underserved communities to make sure that people there are understanding whether or not they qualify for a test, how they could receive that, getting into the inner cities of Crescent and marginalized communities?
Sure. Working very closely with Anthony Jordan Health Center. I've been in touch with Dr. Harbin throughout the week. Highland Family Medicine, Culver Medical, across the University of Rochester system, across the Rochester Regional system, a lot of involvement from my colleagues across the county, particularly those who are working in underserved settings. We want to make sure that those messages are getting out there as best we can. And the message largely is the same. So we want to make sure that that message is consistent. And to the extent that you all can help us to spread the word, I'm very, very appreciative.
Is the percentage of people who are testing positive in quarantine in proportion to what we see in our racial ethnic mix in the community?
I don't have that number in front of me now.
So you said right now there's a shortage of materials across the country, but you said you believe that could be temporary. So could you just explain that a little bit of what could change and what the discussions kind of are around that right now?
So, one of the questions is, one of the materials that's necessary to process these tests is a reagent, is a chemical that's involved in the process that you just heard about. There is a shortage nationally, but the distribution of that supply is also important. So if there is reagent in areas that don't currently need it, we're in touch with the state and federal authorities to see if we can redistribute those assets so that there is time to create more, to produce more, and then deliver later to those areas where it will be necessary later on. So it's not just an issue of total amount, it's really an issue of distribution of that capacity across the region.
For the ones you are prioritizing, what's the quickest you could have results back for a positive case?
If we prioritize appropriately, same day.
And for the ones who aren't a priority, is that the 2 to 5 day window?
Well, those would be the ones that go to an outside lab, the so-called send-out labs. And that's not unusual to us in medicine. There are a lot of labs that will order that are less common or more complicated that will process in a send-out lab, and that's typical in medicine.
Can I point something else to the shortage?
You could explain who would be given the test by priority, that healthcare workers, first responders, people in the inpatients who you need to know to determine their care. And under what circumstances does somebody in the community be considered a priority or eligible for a test these days?
So if they're a person under our investigation in the health department, if there's somebody that we uncover through our contact tracing procedures, we will prioritize that, because we are setting a higher bar for testing within the health department. And if we believe that that individual's result will impact our approach to the community, to be able to provide you all with accurate information, either to raise or lower our level of awareness around a particular venue or mode of transportation or what have you, that's the kind of information that we're going to want to prioritize from the health department perspective.
The CDC said today that almost 40% of people who are hospitalized with COVID-related illnesses are under the age of 55. So I guess that sort of there's new data, I guess, that's showing that in the United States. So if I'm at home and I hear that, I might say, well, how do I know if I'm bad enough to say, hey, I need a test? Because, like you said, doctor, most of us might get it and recover at home, but if I'm in that age group and I'm seeing that number is increasing here in the United States, how do I know when I'm bad enough to ask for the test?
I think it's always best to contact your healthcare provider. We don't want people to try to make that determination on their own. We would much rather be looking ahead at what the circumstances are around your individual care needs, for example, than to have you at home trying to figure that out on your own. The other point to recognize is that the data are changing rapidly, and the profile of individuals that we might have hospitalized last week is going to be different than the demographic that we might hospitalize this week and weeks to come, because it's based on what is known about the community prevalence. And 2 weeks ago, the understanding of community prevalence was very different than it is today. So we have to consider all of these things when we undertake the question of whether to admit somebody to the hospital or not.
And I'd just like to echo what Dr. Mendoza said. You need to call your primary care doctor. The indications for admission would be irrespective of COVID-19. It would be similar to pneumonia. You could ask the same question. You know patients in the community that have pneumonia. We call it walking pneumonia. They may or may not get any antibiotics depending on what it is, and they stay at home and they're fine. Some pneumonias are so severe they need to come to the hospital. Your healthcare professionals know what the indications are for those sort of conditions and when you should come to the hospital. So please call your healthcare provider in those circumstances.
The indication of community prevalence is based on the data, and we know that we're not getting very much data because we're testing only the highest priority people. How do we evaluate the community prevalence? How do we even know where it is and how important it is for people to stay inside or take other actions?
Well, I know Dr. Mendoza is going to comment, but I want to comment about that. I think that's very important, and we need to know that data eventually. It's not.
All right, you've been watching medical experts from URMC talking about local testing, how most people won't need to be tested. President Trump is speaking right now, so we're going to take you there live.